monthly basis. Just to let you know that we're going to be running this on a monthly basis during the year and take a break over the summers, but looking forward to hearing from local and external speakers on what they've done about a learning health system so that we can learn from them. So thank you for joining. I'll pass it on to Noah.
Okay. Hi, everybody. I am so thrilled to introduce Laura. I have a few things I wanted to say about her, mostly kind, before I hand her the mic. Laura is first and foremost, a mom of two, three if you count her husband, Matt, and you probably should. She loves sports. She also loves leadership and coaching and teamwork, and I think these things are intertwined. She happens to like wine. That's probably just an aside. She's a good friend, a remarkable colleague, and she's somebody who, from the moment I hired her as a postdoc in another lifetime, suspected might eventually one day become my boss. And to be honest, I really look forward to that day because she thinks really carefully about how to use and advance evidence-based approaches, not only to the health system, but to people and teams and organizations so that they can reach their goals, which is super relevant, I think, to what she's going to be talking about today. During COVID, of course, Laura worked and parented, as so many of us did, but she's not one to sit on the sidelines during a crisis. I was so impressed to watch as she co-chaired the behavioral science working group of the Ontario Science Table, leading to a whole host of very, very important and meaningful and impactful recommendations. And just sort of looking back over the last 8 years since I met Laura, you know, she's earned funding as a PI, as a researcher from CIHR multiple times, from Diabetes Action Canada, Accreditation Canada, other sources that I probably don't know of. And of course, she's now supported by the Institute for Better Health at Trillium, where she's the scientific lead, specifically responsible for driving forward the learning health system there in Mississauga. And so I think we, you know, really looking forward to hearing from her how she's doing that and how we might adapt what she's learned here at Women's. So really looking forward to hearing from, you know, what she can teach us over the next number of minutes, and handing over the mic to her now.
Thanks so much, Noah. I will get you back for the long and embarrassing intro later. But I will say that I hope for all of you that you have a Noah in your life that will hype you up when you otherwise won't hype yourself up. So as Noah mentioned, my name is Laura DeVoe. I wear a lot of hats. None of them look as stylish as I wish they did, but hopefully they make a difference. I'm the scientific director at the Institute for Better Health at Trillium Health Partners, and excitedly one of the new leadership fellows with the International Women's Forum. I'm going to walk you through, I have 21 slides for those of you that are like, how much is left? You can track as we go through. But really, I would love for this to be as interactive as possible. So feel free, I will try to monitor the chat, but sort of put up your hand and we can make this as interactive as possible so that it's as meaningful as possible. But this really is about the who, what, why, and how of learning health systems, and sort of what I've learned along the way. These are the questions that I received or the things that I heard this group might want to know. So how did we adopt a learning health system framework at Trillium? So value add of this approach versus what existed before this approach, how it was developed, but really more specifically how it is developing, because it's an iterative and ongoing process at Trillium, how we set objectives, necessary building blocks, lessons learned, so what we might do differently, and the sequence and key. So these are the things that I heard you might want to hear about. If I'm overly, which I tend to be, I think we'll be able to address 1 to 5. So let's see how we do. Kicking things off with the why behind the learning health system. I advanced a little bit there. This article, it's really small, so you might not be able to see, was published in 1973. So that's 50 years ago. And for those of you that haven't seen this, It's essentially a study coming out of Vermont where the regional medical program director said that a goal of our program
This is annoying.
is that all Americans have access to great advances in medical
Why are
care.
we on a call right now?
Sorry.
Why are we on a call right now?
Maybe we can mute those that are having some background conversations. Thanks. And so they found out through this study that there's a 19% probability that a child in Vermont will have a tonsillectomy by age 20. What was even more interesting is that in the highest service area, this was 66%, and in neighboring communities to that highest service area, it was 16 to 22%. And there were no difference in demographic characteristics of these communities. And so the difference was attributed into how we're providing care and service delivery. And again, this was 50 years ago. So all I want to take away from this slide around the why is that the system and policy tweaks we've been trying for the past 50 years aren't working. So we need to do something different. And the mission of Trillium Health Partners is to create a new kind of healthcare for a healthier community. How do we then move past the history of persistent variation? How do we learn from what works and what doesn't? And so IBH is about 9 years old right now, and we were built expressly for this purpose and to address these questions. It's a different type of research institute, and I'll talk a little bit about that in our time together today. But really, our job in the science portfolio at IBH is to partner directly with our hospital and patients to change the system and learn from and with them so that we can reach our vision. So when we think about definitions, quite specifically in a Canadian context, here's one of a learning health system. It's a combination of health system and a research system that is across all levels, anchored in citizen and community needs, driven by timely data and evidence, supported by appropriate decision supports, governance, financing, and care delivery. And it's enabled with a culture of and competencies for rapid learning and improvement. So really, it's a union of the health system and research, which we'll dive into a little bit more there. Some people describe a learning health system as quality improvement on steroids. I think it will be interesting to dialogue with this group around where and how you make coherence of that concept, because we often use the terms and language we're familiar with to make sense of something new. But there's 3 key principles of a learning health system that I want to highlight building off that definition. It's the flow of information. So we talked about data. We hear a lot about data-rich EMRs. It's the flow of evidence. It's the flow of data. It's the flow of strategy, operational planning. It's research embedded into decision-making, which we will most certainly dive a little bit more to in our time together today. And the one I want to emphasize the most is that it's really about people as the catalyst for change. And we talk about data and evidence in learning health systems a lot, but healthcare and health and the delivery in our sector relies on humans. We operate in the business of human behavior. So I really don't want to lose sight of that as we go through the conversation today. For those of you that are visual like me, the next 2 slides are for you to help us sort of visualize the concept a little bit more. Traditionally, what we see is at the top of this diagram. We see research and care delivery as separate and distinct enterprises. They may be happening in separate institutions altogether, where research happens in an academic institution and care delivery happens in hospitals. We then evolved to a model of knowledge translation where those siloed organizations or teams were conversing about their respective realities and what they were learning. The evolution of that model in a learning health system construct is really about the embeddedness of applied research and evidence supports. And so the intersection of the Venn diagram here is really meant to represent the fact that the questions being driving the inquiry from a research and evidence perspective are informed by the realities of care delivery, and the operational decisions and strategic planning of care delivery is informed by what we are learning and what's emerging from a research and evidence perspective. So it's really an expansion of that KTE model for those of you who are familiar with that term. There's a lot of synonyms again, but hopefully we can align on the concept in our time together today. So here's where, in my experience and our experience at IBH, we often see a disconnect in terms of how people are thinking about a learning health system concept. It's really a layering of learning units. So at the micro level, that's at the bedside where patients and clinicians are learning together and inquiring and being curious about what's happening. Then we sort of build up and out from there where healthcare teams or units or programs are learning together. Then the organization learns. But you don't have a true learning health system without embedding sort of beyond the organization and connecting with the system, regions, provincially. So just highlighting here, we'll spend most of our time talking about the sort of meso level, but recognizing that the micro and macro are also part of this as well. And at Trillium and at IBH, this is the journey we are on. So we have not fully realized all layers of these learning units, but rather recognize that once we reach maturity, that it has learning operationalized at all of these nested levels. And if we don't have our learning linked across these levels, then we won't be solving problems at the organization or system level that matter and create value at the bedside. So one of our patient partners, Maureen Smith, uses the example of the wobbly stool. And when you look at this wobbly stool, it's essentially that when we are driving forward research, we have very well developed methodologies, approaches, processes. We've made significant advancements in the last several years around processes, engagement methodologies for working with our health system partners. So whether that's implementation labs or applied research. Where we're newer, but investing our time and energy is the importance of having partnerships and processes between researchers and patients, families, and communities. But our maturity with each of those sort of legs of the stool is not quite the same. And it's vital to embed patients as partners at all learning opportunities so that we obtain their views, bring their perspectives to the table as to the natures of the problems we're facing, helping synthesize existing evidence and contextualize it, and then redesigning future models of care to support rapid cycle learning and rapid cycle evaluation. So here's where I'm going to slow down a little bit and walk you through the learning health system model that we've developed and are operationalizing at the Institute for Better Health and Trillium Health Partners. I'm going to stay on this slide for a little bit, and then we're going to zoom in and work through some of the components. So one of the things that I'm not going to focus on in my talk, but we can most certainly unpack in the discussion if it's useful, is that a precursor to this engine, and one of the things we've learned at Trillium is that we need, before we could even conceptualize this or start to operationalize a learning health system approach, we needed to have a clear vision of what it is we were trying to achieve as an organization. We then needed to have a coherent concept for what it meant to be a learning health system. And what I will say to you is this sort of yellow box was a 5-year endeavor. So it doesn't happen quickly because it's all about relationships and understanding people's roles, people's accountabilities, people's incentives, pain points, what keeps them up at night in terms of what they're trying to solve for. And then once you have that alignment and that safety and that expertise and those relationships, it's about understanding the expertise you need to solve the problems that are keeping our clinicians up at night, that are keeping our leaders up at night. And so that's the sort of precursor that went into the learning health system framework and the expertise that we'll unpack as we go through. So we've been consistently using this framework for the last 2.5 years, and I, suspect if we live true to the values of a learning health system and what we're building, that we will see iterations on this over time. We will try and fail, we will pivot, and we will adjust both from the work we're doing internally and the work we have the pleasure of partnering on within the system. What you'll see here, and for the scientists in the group, no, the scientists did not make this diagram. We engaged people with much more design expertise than we have, but we've presented the framework as a learning engine. and it creates motion in a production line. So for this engine, the products you can see here are the quintuple aim. So it's fueled with equity as an overarching perspective and aims to achieve downstream outcomes of health system affordability, so cost, an integrated care experience, so improved patient and community experience and caregivers, health workforce sustainability, and then population health and quality care. So again, those are the outputs that this engine is working towards. What you'll see in the center of the diagram here is that the engine has 5 learning gears and 3 health system gears that describe the intersections of research and care delivery. These gears, again, intersect with one another and result in sustained motion. So when you think about that earlier slide where there was an overlapping Venn diagram, there's consistent and continuous partnerships between individuals in operational roles and those with the respective expertise you see in the gears. Like any engine, this engine requires a constant infusion of fuel and accelerants, and that's what you'll see at the top of the diagram. So here you'll see the importance of leadership, scientific expertise, patient and family partners, community partners. I won't read them out all to you, but there's multiple contextual resources and human personnel resources and partnerships that are required for this engine to run. On the bottom, you'll see that there's also moderators and brakes that ideally help to moderate the engine and not brake. So you'll see both of those terms there because they are important functions, but if we don't think thoughtfully about the way things need to evolve and how this work is governed, that it may create obstacles to realizing the goal of a learning health system. So we're going to take a few moments to focus on the gears and outputs, as well as the fuels, accelerants, brakes, and moderators. And one of the ways, this is where I'll try to keep an eye on the chat and we can answer questions as we go, but trying to keep this at the 40,000 foot view, what I hope you take away from the next few slides is the scientific expertise that comes to bear, the types of questions that you might ask in these different learning gears, irrespective of your role, whether you're leading research, leading operations, or providing care, as well as the types of partners that, from a research perspective, the types of partners you might seek out within your organization. Let me just take a moment to pull up the chat so I can keep an eye on that as we go. Okay.
I've just made note, Laura, for anyone to type in any questions at this point, and then after your presentation, they can feel free to put up their hand, and yeah, we'll monitor a Q&A.
Great. I will try to keep an eye on it, so if I can answer them in real time, that I will, but I'll leave a good amount of time, I hope, for dialogue. So here, again, as I mentioned, is equity as part of the quintuple aim that is central to all learning health system gears. This is something that, you know, transparently and honestly, I think none of us can say we do exceptionally well, other than making the commitment to learning, identifying best practices, and specifying the values through which equity can drive the other 4 outcomes in the quintuple aim. So while there are many definitions of equity, here we have defined it as the elimination of health disparities between groups with different levels of social advantage and disadvantage, whether that be race, gender, socioeconomic status, what have you. And in order for the learning health system to achieve equitable downstream outcomes, whether it's related to cost, patient experience, population health, or workforce experience, equity has to be addressed alongside that here. So here's the zoom in on the learning gears in the Learning Health System Action Framework. So they represent the various types of research methods and evidence central to the iterative learning that happens at all levels of the system. This isn't meant to be sequential, and in practice, we sort of operate like a pinball machine at times, bouncing around from one to the other. But in any given project that we have at the Institute for Better Health and Trillium Health Partners, there's expertise across multiple gears that comes together. So it's not It really is what we describe as team-based science, as opposed to individual portfolios leading independent programs of work. So O'Neill, I see your questions. I will put a pin in that one, because I think that will be a great dialogue as we get to the end of the presentation. So one type of evidence here is insufficient, which is why we recognize that sometimes we might start with an evidence synthesis and in parallel pursue analytics and population insights. The three dark blue gears you'll see here represent health delivery sectors that work together as a whole system. And so I'll use Trillium as an example. Just working with our hospital partners is insufficient. There's social service and community health providers that we need to partner with. We need to think beyond traditional partnerships. There's also our OHT. And so again, it's constantly asking who's here, who's not here, where should these services be provided, and building those partnerships over time. So as much as I talked about the first 5 years being on relationship building, that was internal to the organization. And now now that we have the coherence on the concept and working in this new way within THP, it's about understanding sort of outside of our walls and with the community, how we continue to build those partnerships. So those three health system gears represent hospitals, specialty care and primary care, long-term care, home care, community care, and public health, and then community organizations, municipalities, educational institutions, and social services. So now we're going to dive into each of those gears individually, again, recognizing that in practice, this work is often intersecting, done in parallel. If we're really lucky, we get to do it in sequence, but it's never quite as clean as one step after the other. So the first learning gear is around analytics and population insights. And this is really about using data, both quantitative and qualitative, and advanced analytic approaches to understand populations and health service needs. This includes access, current access, gaps, inequities, but also preferences and aspirations. So it allows you to ask the question, not just who are we seeing, who are we not, who's on the wait list, but who's never making it to our doors, who never gets a referral, who are the people in the population that in our future state we should be serving, whether it's in the walls of the hospital or not. So the types of questions you would ask in this year are, what are the system gaps and what's driving them? Where are the inequities? Instead of whether, it's where. We know that they exist, and so it's being clear about understanding and specifying where they are. What problems are we solving for? And what are the patient, caregiver, and community preferences and aspirations? Again, this question is recognizing that, understanding our current state isn't necessarily going to help us close the gap between the type of care we're providing now and our aspirations for what our organization or system provides for populations in the future. So if you're taking this from the perspective as a scientist or a researcher, then the types of health system partners you might be thinking about are business intelligence functions in your organization, data decision and analytics, program planning groups, clinical informatics, patient and family advisory councils. So again, different organizations might use different language, but what we're trying to illustrate here is that there are enabling functions within an organization, as well as programmatic and clinical functions that need to come together to contextualize and inform these analytics and population insights, and perhaps power them as well in terms of where that data comes from and how you access it. So the quantitative research methods here can be simple, but often are a bit more sophisticated when they're operating at a population level. So they could be descriptive, predictive, or causal. It could be machine learning algorithms. Similarly, with qualitative research methods, it could be ethnographic studies, focus groups, world cafes, nominal group technique. The methodology, the list of potential methodologies is long, but can be well suited to the questions that the collective is trying to answer. And the data are derived and integrated from many sources. So EMR data, if that's what's available, community data, patient-reported data, social data, census data. And when brought together, these methods help us better understand the problem. And one of the quotes that I think Noah had in an early presentation when we first started working together that I use often is an Albert Einstein one that says, if I had an hour to solve a problem, I'd spend 55 minutes understanding the problem and 5 minutes thinking about the solution. And that's really what the sort of key focus of a learning health system is if these are persistent problems that we've been trying to solve for 50 years, let's really make sure we understand the problem well so that we can identify together strategies that are likely to address the root cause. I see Vanessa's comment around, does IBH see themselves as liaisons or agents to bridge clinicians' operations and research at THP and close some of these gaps? The short answer to that is yes, but I would say the evolution over time is that we all, like operational leaders, and the future vision is that managers, frontline clinicians will similarly see themselves as an opportunity to bridge. We're an organization with over 15,000 staff. So that's definitely an aspirational goal, but it started out with IBH as the sort of agent of facilitation and bringing people together. But I'm pleased to say that now I sit in on conversations where I don't need to explain to the manager of quality improvement what a learning health system model is, because we've spent the last 9 years now socializing that concept such that it is really embedding into the fabric of how we think and how we plan. So second gear is evidence syntheses. So here it's about leveraging what we already know and not needing to reinvent the wheel. So rapid syntheses of existing evidence to understand successive failure of solutions to similar problems that have been tested elsewhere, but not just sort of interventional syntheses, but syntheses around the problem itself and barriers, facilitators, contextual contributors to whether or not something works or doesn't. The types of questions we're asking in this gear are what has worked and not worked elsewhere, what's key to the success of that intervention, and what's the adaptable periphery of that, what can we localize. I always use the analogy here of baking a cookie. So what's your dough and the ingredients that you have to have, and what toppings can you localize with, depending on your context, resources, what have you. What conditions are key and what barriers need to be addressed. So here, if you're looking for partnerships, in addition to researchers with relevant expertise, you may be partnering with health system librarians, with those developing clinical guidelines, with provincial and federal evidence synthesis supports. So a lot of different, I think if we were comprehensive in terms of operational roles within a hospital, to think of women's for a moment, I think this list could be quite endless, because in a fully realized state, you would hope that any program team sort of advisory group has the opportunity to connect with and digest evidence relative to whatever strategic priorities they have. And there's many robust methods that are used to review the literature. I won't dive into those now because I'm sure this group is quite familiar with them, but it really is just about systematically assessing what is in the evidence base and the strength of that evidence. Important to remember here, I just saw O'Neill's question earlier around equity, that when we talk about patients, caregivers, providers, and community at the center of the learning health system model, our evidence is flawed in terms of whose perspectives and experiences it represents. And so, again, just trying to emphasize that none of these gears operate in isolation, but rather require explicit energy and intention around being clear about what we know from the evidence and what it can't tell us, and what we need to supplement with local experience and local evidence. So the third gear, which is intentionally at the center, as I just mentioned, is around patient, caregiver, and provider co-design. So here we want direct engagement with and subsequent co-design with these groups that are impacted by the problem that we're trying to solve, but also those who can move these solutions towards successful implementation. So it's not enough to just include patients and caregiver partners, but rather who are the clinical receptors or service delivery providers that will intersect with those patients and where. Who are the managers or health system leaders that control the budgets and are responsible for workflow mapping and strategy planning? So all of these considerations are things we want to ask ourselves. So in this year, we'll ask, what are the user-centered design conditions identified by these groups? What considerations are most important if we have to prioritize? The reality is we work in a resource-constrained environment. How can technology be used in a way that alleviates challenges as opposed to adds additional administrative or workflow burden? How do requirements differ for and across equity deserving groups? And what are our feasibility constraints? And in this year, I would almost say, I almost want to bold the question around feasibility constraints, because it's important to have that as an explicit part of the co-design process so that there's diverse and informed dialogue around working with the resources that we have. And similarly, talking about aspirationally what we would hope to be different. Health system partners here include innovation and user-centered design experts, clinical programs or clinical networks, health informatics, patient and family experience councils again, the health system leaders responsible for oversight of these programs, and so on. What do I see as the biggest challenges in data collection for these types of studies? That's another great one, Chris, that I'm gonna put a pin in until we get to the discussion. But there are many, but again, it requires partnerships between everyone to discuss. Fourth gear is implementation and reach. So here we understand the problem. We understand who we're serving, who we're not serving. We understand what's worked elsewhere, how that relates to our context and our service delivery platform, and had dialogue together around what we believe we can leverage from what's done elsewhere and what we need to localize or contextualize. So once we've aligned on those things, this then becomes about how do we systematically convert the sort of product of our learning health system approach and other evidence-based practices into actual sustainable practice change. And this is the really sticky, really messy work that I know some of us get really excited about and spend a lot of our time thinking about in implementation science, but is still relatively new for a lot of people from an operational mindset. So here we want to ask the questions about how do we stage implementation? What change management or implementation strategies do we want to use, and what communication channels should we go through? How can behavioral motivation be built? How do we train people to work differently? How do we train people or support them in receiving care differently? And there's two things I want to point out. I'm again biased because this is where a lot of my work sits. And I'm thinking back to when I was sitting on the Ontario Science Table, and one of the things we chatted about or sort of brought to light from the behavioral science working group is that the least effective way to get someone to change their behavior is to tell them to do something differently. I don't know about you, but I get told all the time by my kids what I should be doing. I don't like to hear it, no matter who it's coming from. And so it's important for us to think about, how do people value their roles? Where do they find joy at work? How do we take, this co-designed and evidence-based approach to doing things differently and help people operationalize it in a way that allows them to be their best instead of just asking them to work harder or do things differently? The second thing I want to add here, just in case it's a tactical insight that's useful for you in your roles as you leave today, is that what I've seen time and time again in my work is seeing attribution bias play out in a variety of healthcare settings. And what attribution bias boils down to is that we assume when we experience something, whether it's as a patient, as a researcher, as a leader, as a clinician, that it's a product of someone's motivation and not their context. And in a lot of the work, if not all, that I've done in health system change, it's often not that people aren't motivated or aligned to the vision of doing things better. It's that either their context limits them, their workload is too high, the administrative burden's too big, there's barriers to accessing care. And if we actually can check ourselves and remind ourselves to look at those contextual factors, it helps us understand how to build implementation strategies that address the context and not the people directly. So here you're looking for partnerships with quality improvement teams, project management teams, maybe strategy teams, health informatics, people responsible for change management, their roles and titles may be very different. It may be a distributed responsibility, but really you're trying to bring together those that will be doing work differently, as well as those responsible for supporting the change. And I know there's lots of expertise at Women's, quite specifically in this gear around implementation science, to help think about how we can most robustly and in an evidence-based way roll out the brilliant new models of care that we've co-developed together. So the last gear is about evaluation, feedback, and adaptation. So here, it's about using evaluation methods, realist evaluation methods being one of them, to measure how well complex interventions, which have lots of moving parts, are working at a population level, and under what conditions they're working and under what conditions they're not. And there's constant feedback via intervention data to adapt the intervention to match patient and population needs. And so here, it's really about evolving the way we evaluate, so that we're not requiring that we wait 3 years for a trial to end to understand what works for who and in what circumstances, but rather when we know something's not working well, feeding that back in real time so that we can pivot together or decide that, there isn't a sufficient risk here, or we're not changing outcomes such that a pivot doesn't need to take place. So the types of questions we're going to ask here are, what type of evaluation logic model should we use? Are we actually cementing change processes, or are people approaching this as if it's a pilot project that's sort of a one and done? What degree of reach do we have across equity deserving groups? Are the hypothesized outputs or early outcomes being achieved? If we don't see movement on the things we expected to see upstream, we're likely not going to see the downstream impact on the quintuple aim in the way that we would hope. And that allows us to conserve resources and responsibly pivot so that we're working towards the outcomes that we're trying to achieve. Are there unintended consequences, something we didn't anticipate? And what adaptations are needed to cement the sustainability of a new way of working, and then scale that to other programs, other areas of the system, what have you. So here, partnerships may be with quality improvement teams, performance management teams, business intelligence, those responsible for evaluation, whether those individuals are embedded within programs or embedded within a research institute, and so on and so forth. Nope, I did not go too many. So here, I won't spend a ton of time here, but when you think about that layered, the sort of micro, meso, macro elements of a learning health system, again, re-emphasizing here that one of the things we see often is that when people are thinking about a learning health system, they sort of stop themselves from dreaming big. And so if we fully together realize the concept of a learning health system, it's not just Trillium, it's not just Women's College. It's partnering in our system more broadly to have sort of that population health system level connectivity that allows us to work alongside and across the current silos that we have. So it's inclusive of formal healthcare sectors, in acute care, specialty care, primary care, home care, as well as other sectors that we all know impact indirectly on health, educational institutions, social service agencies, what have you. And so these groupings and examples of health organizations isn't meant to be comprehensive or exhaustive, but is rather to show how learning health systems would impact within and beyond the walls of any one organization, to influence health more broadly and not just healthcare. So again, here with this group, I won't spend a ton of time on this slide, but key outcomes include the quintuple aim. So with equity as an overarching outcome, and the 4 elements that everyone's quite familiar with. So here, we're really aspiring to balance these outcomes across sort of the broader health system gains of any initiative that we're undertaking, recognizing that this is an incremental approach. And when we tweak things in one year, sometimes we see cost go up, or sometimes we see, patient experience go up at the expense of health workforce sustainability or clinician experience. And so it's about understanding both the intended consequence, the unintended consequences as well, so that we can continue to calibrate over time. Again, Just to repeat that at IBH and Trillium, we're continually on this journey. What I'm sharing is the model that we've conceptualized and that we are operationalizing, but we quite routinely learn what we don't know and, make mistakes, iterate, and grow together. But as you'll see as we wrap up, that's sort of our North Star and guide in our work. Here we'll see the fuels and accelerants a little bit bigger for everyone to read. And this is when we think about those relationships that fuel the learning health system engine. It's not just partnerships between individuals, but functions within a hospital, to use that example. Also resources that will allow us to operate smoothly. And I would say, while we could talk about the learnings that we've had quite specifically around, our data at Trillium or our ethics board at Trillium or what have you, there's an element of local context that we can't replicate from one organization to another, because it requires those functions in any given organization to come together and say, well, here's what's feasible, here's our constraints, here's what we're operating under. And again, bringing those people together to learn and align on, if this is the model we're driving forward and we've reached a point of coherence in that vision, then how do we all redesign our work? Because it can't happen without everybody redesigning their work in line with these principles, and new ways of working are challenging for everybody. So this creates not just learning relationships, but learning networks, both within and across organizations. These are most certainly not my area of expertise, but again, I would say where we have almost the most conversation, and we really need to go slow to go far around the alignment of health system priorities and how hospitals are paid, how the system is incentivized, how the people within it are incentivized, and really have intentional conversations about lining those things up, which are conversations we have continually at Trillium about saying, okay, well, we see a disconnect here. So how do we all move forward together? Laws and regulations, privacy, governance, and what have you. This is again, the go slow to go far together conversations where people, if you aren't aligned on the concept and how you're operationalizing a learning health system, then it becomes almost impossible to have these conversations productively, because you're either speaking a different language or operating under different incentives and strategies. So I'll close with some key cultural attributes for health system learning that we've learned over our tenure here at IBH. And it really does come down to, in addition to those principles I mentioned at the beginning around information flow, people as the catalyst for change, that there's humility and willingness to fail. And that requires a level of psychological safety that takes a lot of time to build. And so I often say to our team of scientists, quite specifically, our job isn't to know things. Our job is to learn things from and with our partners. And that's a big shift when you've spent your career, whether you're a scientist or not, working towards a certain level of expertise and being socialized that your value is in what you know, that rather than your ability to learn. So learning health systems require a clear vision and then a corresponding culture shift. It's messy. It requires a deep breath every now and again, and reorienting yourself to that clear vision and what you're trying to accomplish and who you're trying to accomplish it for. Needs environments that encourage sharing the missteps. So instead of talking about what you got right and the grants you did get, talk about the ones you didn't get. Talk about when outcomes weren't what we wanted them to be, and dialogue together and get curious about why we ended up there. And in environments of incredibly smart and accomplished people, it's a willingness to show failure or vulnerability, and that's not necessarily part of our culture, and requires, leaders, and whether formal or not, to be vulnerable and say, I don't know, who might know and who needs to be part of this conversation. And even if we come together, again, it's not about knowing, it's about learning together, and everyone has a piece of that puzzle to contribute. However, I can say from this point, from the point we're at in our journey, that when you commit to these things and framing the concept and the vision properly, the ability to learn from failure leads to a significant amount of organizational resilience and strength. And it is such a gift to be able to work alongside committed, intelligent colleagues who sort of sit on the same side of the table as you, to come together to solve problems that really matter and will create a lot of impact, so that, you know, when the next generation grows up and seeks care, that we're not asking them to experience the same things we did, nor are we giving them a system where they're inheriting the same problems that their parents tried to solve. So I will pause there and stop sharing so I can see all your faces. And then we can dive, I'll follow your lead, but we can dive in whatever way is most meaningful for the group.
Thanks so much, Laura. I do see Rulan has her hand up. So folks, feel free to raise your hand or type in the chat and we'll attend to those comments.
Sorry, thank you so much. That was fabulous. I think I'm just gonna ask the same question that Erin just posted. Could you give us like, are you focusing on the macro, meso, or micro? And then could you give us an example in the area that you guys are, you know, started working in, and how you work through that process? And just give us an example of sort of what you think has worked well for you guys at Trillium.
Yeah, so I'm going to give an example of that kind of spans micro and meso. The question came from micro, but then was elevated to include the team. So there's an example that came out of nephrology, and if there's anyone, well, there's probably a lot of people with more clinical expertise than me, so please forgive me if I'm inaccurate in the specifics, but the problem surfaced that we have a lot of patients that fail their attempt at home hemodialysis. And I don't remember the specific numbers, despite us doing a presentation on this a week ago, but essentially it was an overwhelmingly large number, despite the known clinical benefits for this population. So, you know, clinicians, IBH, like representatives from clinicians, IBH, and the nephrology department came together and said, okay, well, what do we know about this currently? And what resources do we have to try to understand this problem? So I'm going to hop, skip, and jump over some lily pads here, but essentially we did some mixed methods work that involved characterizing the patient population that's seen. So sort of three groups: those who are successful with home hemodialysis, those who quote unquote fail, not that I love the language, and those who never entered into the possibility of home hemodialysis. We then did some qualitative interviews to understand, again, with all three of those groups, try to understand, well, what's contributing to success, what's contributing contextually to failure, and then in that third group, you know, are we missing an opportunity to connect people to things because we're perhaps making assumptions about motivation, level of interest, what have you. What we learned also, although I won't dive into this, from speaking to clinicians, is that because of resources that were deployed in a suboptimal way, they were hesitant to engage more people in this because they didn't want to set their patients up for failure. The types of things, again, this is not exhaustive, that we learn from patients is, one, like, you know, this is something I'm still it's not a motivation issue. It's not a fear, but it's that I got one education session and it's not enough. You know, there's more troubleshooting I need to do. I need more support with the equipment itself, not even sort of the clinical education support on how to make this massive transition in my life from seeking care in a hospital to my home essentially becoming a part of my care delivery. I'm sure this won't come as a big surprise to a lot of you, but similarly, we started to hear things that we had no knowledge of, such as, well, this is really great, but now all of a sudden I'm ineligible for home insurance because of the circumstances of having a home dialysis machine and the flood risk that presents. And so we learned all of these other things that we would have previously, one, never known, but were outside of our scope of providing care, that helped contextualize why we had so many patients quote unquote fail on home hemodialysis. And so now this is work that's happened in the last year. The nephrology program is redesigning and reallocating their resources in line with what they've heard creates the most value for the resource they have. Stay tuned over the next, 6 to 12 months as to whether or not they start to see differences in those numbers. But sort of the early indicator of a lot of aha moments for a lot of people showed the importance of thinking about the different groups, integrating insights across and understanding that the solutions to the problems we're facing in the hospital often don't exclusively lie outside of our control, but often what's contributing to our success or failure is actually inputs from a lot of different elements. So hopefully, Aaron and Rulon, that was a helpful example of when something comes from the micro level, at the very least, we can elevate it up to include teams, managers, leaders. And then if that particular project was to establish proof of concept and socially promising solutions, then it becomes an escalation sort of to regional networks and conversations more broadly about whether and how we can learn from and with each other and scale great ideas.
Thanks, Laura. I'm going to go to Vanessa in a second, but I just remembered Chris had a question in the chat around enhancing and supporting studies to ensure maximum sensitivity and inclusivity, but also response rate and data quality. So what do you see as the biggest challenges in data collection for these types of studies, initiatives?
I would say, how much time do you have, just to be cheeky? But what I'd actually say is, and this may be an unpopular opinion, is that you need to be comfortable with imperfection and ambiguity. And so there are best practices in equity, diversity, and inclusivity in terms of data collection and recruitment. That's one component, but even like those relationships and community embeddedness, I don't know if Ambreen is on the call or not, but with the work that is happening at Women's with Impact, like that takes time. And while those relationships, partnerships, practices are being built, I think it's about the intentionality around, okay, well, this is the data we do have. What can we say confidently with it? What can we not? What hypothesis does this data generate? But also who's not represented here? And if not, how do we ensure that we're at least taking a step forward in terms of ensuring that representation. So I think there's a lot of work to be done, Chris, knowing your role on to get more comprehensive data sets and inclusive data sets. But honestly, I think that for the next 5 years, we need to get, and even that may be aspirational, we need to get quite comfortable with asking ourselves, what are the limitations of this? And if these are the limitations, what is the best available option we have around how to bring voices to the table? And I think that's where we can hold each other accountable to saying, it's not we did our best, but we need to move forward anyway. It's committing to, again, equity as a core driver and saying, okay, well, if we don't have the same number of participants, how do we give a louder voice to a smaller subset and have them sit beside us at the table and interpret what this data tells us and what it probably isn't telling us because we didn't have a representative sample. So hopefully that's helpful, although I recognize it's not a cut and dried solution to the question that you asked.
Thanks, Laura. And it looks like you've given Chris and all of us a lot to think about. We'll go to Vanessa and then O'Neill.
Hey, Laura, thanks so much. Okay, so considering you've been at this at IBH for over 10 years, where do most of your questions come from and where do they land? And how often does that transfer into the micro space, considering this is messy work and it's adaptive? And I'm just wondering the weight of where your work sits at this present time.
That's a really great question. I suspect anyone else would say the same. Not enough of it filters back to the micro level. And I think that's we've all heard that it takes 17 years for evidence to reach practice, but it's balancing growth. And I'm just talking about an IBH perspective. It's balancing growth with integrity, rigor to the learning health system concept, and building capacity within the organization. So I would love to be talking to you all 5 years from now, describing, the operationalization of our current vision to have like interdisciplinary frontline staff engaged in not only feeding in questions, but championing the work in their units. But it's a little more opportunistic at this stage. Part of what I envy about Women's in comparison to Trillium is with 15,000 staff, it's going to take us a while to have the full fabric of a learning health system model be operationalized across levels. I would say the weight of the work is at that meso level. So we're working with leaders and managers on the problems that they have. And it really, again, I would say we've left the stage of it being IBH initiated, and now are here, like we have a lot more people reaching out saying, how do we work with you? What would a partnership look like? We just had a meeting last week, the research chairs and myself, with our patient services committee to start the dialogue around like, how do we create a pipeline where you tell us the things that keep you up at night? Because from an IBH perspective, we're all here to have an impact with the skill sets we have. And if we don't know the things that are bothering, the nurse at the bedside in the mental health unit, or the primary care clinicians in our family medicine teaching unit, then we're missing a huge opportunity. So we don't have that pipeline yet. It's on our radar of something to develop. But what I would say is our plates are overfull. It is quite a buffet, but it's a privilege. And it really is the question we ask ourselves as an institute is, if we don't have, like, this is not a problem for someone in our community organization, then it's not something we're solving for, because we have enough of those to go around, and it's hard to keep up. O'Neill?
Thanks, Laura. That was a very wise and probably the most operationalized version of a learning health system strategy I've seen. So kudos, it's really impressive. My very brief question, we only got 2 minutes, is if we put equity at the center, like how do we make people who are marginal, how do we grow their influence? How can they, they're marginal and therefore don't have a lot of influence. And in the quintuple aim, many of the aims are in conflict. So ultimately someone with more clout is going to push in one direction versus another. So like, what materially have you seen change in that dynamic?
I'll speak to, again, I'm most certainly not an equity expert, but some of the ingredients that I think are necessary and some of the movement we've seen. One is that you need a critical mass of people in positions of power. By that, I mean they control budgets, they oversee decisions, who are willing to put in a lot of energy, their political capital and resources to say this needs to be different. I think in my experience so far, that's the top of the list, because those are the people that control who's at the table. They control where resources get allocated. They control the accountability for whether or not that data set is inclusive or reflective of the populations we serve. And again, I did reference at the beginning, budgets and formal accountability, but it's not just, when we think about people in traditional formal leadership roles, but if we don't have that buy-in, then a lot of really great people who are well-intentioned aren't going to be able to move the needle. To your point around I'm going to paraphrase, but like, how do we give them a voice, make their voice louder? I think that how we're currently operationalizing that is twofold. We have partnerships. Again, nothing is across the organization fully comprehensively, but we partner directly with equity deserving groups, Indigenous communities, Black communities, and say, what do you want answered? Like, what are we, instead of a centralized pipeline, we build partnerships with those communities and sit at those community tables and say, you tell us what we should be investigating. And sometimes we'll say, okay, we actually think we can position that for this grant, but otherwise find a small amount of seed funding to support it. And then I think it's about, for those of us that are really quantitatively minded, getting comfortable with, it might only be 1, 2, 3 people from that community whose voice you have, and you have to hold yourself accountable for that having the same weight as, the survey data you collected from 500,000 patients of a medium to high socioeconomic status that primarily identify as white. And that is a challenge, but I think that's how change happens. So short answer to your question, but again, I do think it's not about whether we should be doing something. And we will continue to fail in operationalizing equity at the center, but if we're not taking a step, then we're not getting any closer to doing it. And I think Women's is one of the organizations that we can learn from and with around how to do that well in a way that creates impact. And the last thing I'll say on the note of impact is we don't get to decide if what we did was impactful. It's the communities who have identified the problem and that we are designing for who hold us accountable and hold the ability to say to us, like, yes, that is a solution to our problem and creating impact that is meaningful, or good try, but you missed the mark. And so you need to try again.
Thanks so much, Laura. I know we're just a couple minutes over time, so I think we'll end it there. But as you can see in the chat, I think a lot of folks are really excited. Those who are familiar with you, was great to see you again. And I think to others as well, just to quote O'Neill, like I think you gave a very structured, very it was a very clear kind of explanation of LHS with some examples as well, but it's also very inspiring to kind of see, where things have started, and encouraging to know that this doesn't happen overnight, that it takes quite a bit of time, quite a bit of, it's a collective effort. And I know this isn't the end, like we'll continue to stay in touch and keep learning.
Perfect. Happy to hear it was useful and looking forward to whatever comes next. Thanks for having me.
Thank you.
There. Thanks everyone for joining. We'll share the details of the next few seminar series shortly. Thanks again.